Let's talk placentas, post-states, low fluid, why we get concerned about those things, and how we know when things are okay.
Okay, well, this is a very big topic, but it goes along very much with the most recent study, the big trial where the ARRIVE trial, where people were put into two categories: people who were induced for labor in the 39th week, and then people who were allowed to pass their due date and spontaneously go into labor or be induced by the 41st week. It's that the conclusions were something that I had always thought, and in a way that I always practiced, because when you get to the end of your pregnancy and you are starting to feel like, oh, the baby might be moving a little bit less, or things are moving towards a time where it's time for the baby to come out, things happen to the placenta. The placenta is like a timed organ. It has, maybe not to the day, an expiration date, but at some point around the end of pregnancy, the placenta is really not meant to function way past what your due date is. And we know that this placenta starts to kind of, I won't say break down, but starts to become less robust in its function by a couple of things. One is when we do ultrasounds towards the end of pregnancy, like you're ultrasounding somebody who's in that 39th week or has reached their due date, and you look at the placenta, you often start to see little areas of white or calcifications in the placenta. And those areas mean those are the areas where the blood vessels in the placenta are not as healthy as they used to be. There's not as much blood flowing through it. So calcified areas are exactly what they sound like: hardened areas, unhealthy areas, areas of less blood flow, so less oxygenation. And the more calcifications you see, the less that placenta is really functioning. So if you ultrasound somebody about 39 or 40 weeks and you see a lot of white calcifications in the placenta, it's not a study, but it is the knowledge that that placenta is not as robust as it was several weeks earlier. So in my mind, I start to feel like, well, there's really a time where we want to get the baby out before this placenta really doesn't function at all. And the other ways that we know about these issues with the placenta is in the amniotic fluid levels. So if you ultrasound somebody and you find that the amount of amniotic fluid around the baby is low somehow, maybe not dangerously low, but amniotic fluid peaks at around 34 weeks or something. That's the most amniotic fluid you're going to have. And then it plateaus and then it starts to go down. And the reason it starts to go down is because the place that amniotic fluid comes from towards the end of pregnancy is mostly from the baby. The baby's urinating. So the baby urinates into that amniotic sac, and you see a lot of amniotic fluid, or a combination of the baby's fluids and some fluids that come from the mom. But you have to think in your mind, what would be a reason for there to be less fluid around the baby? Well, it's a cascade of things. The placenta might not be working quite as well. So the baby gets less blood flow through its umbilical cord. So the less blood flow through the umbilical cord means less perfusion or less blood flow to the major organs, one of which, or two of which, of course, would be the kidneys. The baby gets less blood flow to the kidneys, the baby slows down on its urination. So you have to not just think, oh, there's low fluid, we should do something about it, but why is there low fluid? If the person does not have ruptured membranes, she's not leaking that fluid, then it's a supply issue. So the baby's making less fluid because it's getting less flow from its placenta. So you can extrapolate that to mean lower fluid means poorer placental function. So, and that continues to decline to the point at which, if you pass your due date, the baby's much more likely to have less and less amniotic fluid. And again, then you're subjecting this baby to labor that is stressful for the baby, less cushioning around the baby, poorer placental flow, which are the babies that are not going to do well in labor. Those babies that have passed their due date, passed their placental expiration, so to speak, there's less cushion around, less ability to withstand the stress of contractions and labor and pushing and delivery. So if someone's going to end up with a C-section, it's going to be those people. So that's what the ARRIVE trial actually showed, that people who are allowed to go later in gestation, past their due date before becoming induced or before delivery, end up with more C-sections. And that's a complete opposite of what everyone always used to think, because everyone talks about the cascade of interventions and talks about, if you induce me, if you give me Pitocin, if you give me an induction agent, those things are going to cause me to have a C-section. That's just a real myth. So when you're talking about what makes the most sense, it makes the most sense that babies who have poorer placental function will end up not tolerating labor, and they will end up with more traumatic deliveries or emergency sections, et cetera. So that's my kind of take on placental expiration dates.
Question that I thought of was, now we know that the placenta is an organ that throughout much, but not all of the pregnancy, grows and, I don't know, regenerates it all? Definitely grows. At what point in the gestation does the placenta essentially become static?
Well, I don't really think the placenta is ever really static, because it acts as a living, breathing kind of organ, which is always having filtration. It's always having blood flow. It's always doing a job throughout the whole pregnancy. So it's growing and moving up with the uterus as the uterus grows in the beginning and into the second trimester. But then in the third trimester, it's really just, I guess, what you would call plateauing or static, and providing what the baby needs. And if at any point during that point it doesn't provide, i.e., people who get hypertension in their third trimester, hypertension is a disease of the blood vessels. That placenta is made up of the blood vessels of that person. So hypertension leads to poorer placental function, and that previously static placenta that was feeding the baby, nourishing the baby, allowing the baby to grow, now doesn't do that. Baby stops growing as well. So there's actually a decline. So the placenta is declining along with that, the nutrition to the baby. And somewhere along that line, you decide, is the baby better off out than in, because it's not growing? And that's when you deliver those babies.
I have a question about good old gestational diabetes, which is quite has many paradoxical possible features. One of them is a huge placenta. What causes placentas to grow far larger than they should?
Well, kind of the same thing that causes babies to grow far larger than they should. When there's way more sugar in the environment, there is the baby has to produce a lot more insulin to provide a way to metabolize that sugar. And higher levels of insulin will cause the baby not only to grow bigger and weigh more, but have wider shoulders and a wider thorax, and have more fat distributed in the abdomen and the thorax region. And same thing, to support that baby, the placenta is often large and kind of what you would call an overgrown placenta. But usually a large placenta usually goes along with a large baby.
I can't say what causes. With placenta, the issue of cord accidents occurs. Why is a two-vessel cord concerning?
In and of itself, it's really not, because when a two-vessel cord is found, usually an investigation ensues with a detailed ultrasound to look at other things that could have been affected, because when the umbilical cord develops, there's other organs, other anatomy that's developing at the same time. So we worry sometimes that if there's a two-vessel cord, maybe there are other organs like the kidneys or the heart or something else that might also not have been created properly, or with the right amount of vessels, or with the right anatomy. But in and of itself, if it's a two-vessel cord and nothing else is wrong, it usually doesn't really mean anything, except we do have higher surveillance, because It's certainly a possibility that maybe during labor, the baby wouldn't tolerate it as well because of the decreased blood flow in the umbilical cord because of the vessel. But that doesn't usually happen. What I see is it's kind of something to think about or interesting, but we do a lot more surveillance. We do NSTs like to monitor that, but it often just results in a normal delivery and a normal baby.
Okay, yay, NSTs. What's an NST? What is it meant to show? And when is it useful and when is it not so useful?
Well, it's kind of the best thing we have right now to decide whether someone should stay pregnant or they should be delivered. So basically, we use NSTs, which are non-stress tests. So there's nothing stressful about it. You're not doing anything to the baby or to the mom or creating a situation. It has no medication. It's just a monitor. So basically, anybody that would be considered a high-risk pregnancy on the long list of high-risk pregnancies, like we have these order sheets for NSTs, there's got to be about 50 different entities on there, everything from someone who's over 35 to someone who has diabetes to someone who has a poor history in her last pregnancy or hypertension. There's so many things. But basically, if someone meets the criteria on that list, they are, by design, slated to go and have these NSTs, these monitoring sessions twice a week, usually from 32 weeks, but sometimes it's from whenever it's diagnosed. But the reason we use 32 weeks is because from 32 weeks on, we know what we're supposed to see on a monitoring strip of a baby to make us reassured or not. And I think I did mention it in one of the last videos that we did about the different categories of a tracing. Same thing with an NST as when somebody's in labor, when they're on a monitor and we have these tracings that we often have something up on the wall or on a shelf where we can actually electronically see the heart rate of the baby. We're basically looking at a checklist of criteria, like what is the baby's heart rate? There's a normal range of baby's heart rate. We want it to be in there. What is happening to the baby's heart rate at various points in the monitoring session? So is the baby's heart rate staying in that normal range all the time, or is it going up or down or out of that normal range, things that we call like bradycardia, which is slow heart rate, or tachycardia, fast heart rate. Is it regular? Like we can put someone on a monitor and we can actually hear, because we hear the beating when we're watching the tracing, is the baby having a regular heartbeat, which means, you can hear the regularity to it, boom, boom, boom. Sometimes you hear an irregularity, like the baby's heart is beating irregularly. So maybe the baby has a cardiac problem or heart condition or something like that. You can hear that and you need to evaluate that baby. But it's mostly to reassure us. If we see certain things on our checklist during that monitoring session, the patient can be done with their monitoring, let's say in about 15 or 20 minutes. If we don't see the things on the checklist, that leads us to have to do more evaluating. Like, why are we not seeing the things on the checklist? Is something wrong with the baby? Is the baby in such a state where it needs to be delivered? I mean, almost never does someone go on an NST for a simple monitoring session. We see something that says to us, this is an emergency, we need to deliver them right now. But it does happen. If you put a baby on a monitor and you know where the normal fetal heart rate should be, and this baby's heart rate is nowhere near that, if that's the real baby's heart rate, you've got to deliver the baby. So basically, if it's 32 weeks and beyond, obviously those babies are deliverable, survivable. And if they don't belong in the womb because something's wrong, then they belong outside.
One of the things that people try sometimes is to get their own Doppler and check their baby's heart rate. Can you learn anything from just a quick check of the baby? Grab a Doppler and say, wow, I found the baby's heart rate. Wow, look at it go. And then a minute later say, oh, everything's fine. Or is that just, oh, you have discovered the baby's heart rate, congratulations?
There's really two reasons why we tend to not encourage people to buy home Dopplers. One is because every single time someone tries to listen to the baby's heart rate at home, if they're not a skilled person, like a nurse who does this regularly or a physician, sometimes it leads to them either finding their own heart rate and then calling in a panic, like, my baby's heart rate is 80. No, that's your heart rate. But if it's really the baby's heart rate, you better go right in, because if it is, we need to section you right now. So for that reason, we don't encourage it. But also, we don't encourage it because we don't want people to be falsely reassured because they heard the heart rate of 150 for 3 seconds on Tuesday afternoon, because that's a second in time. And just because you heard it right then doesn't mean that 5 minutes later or 10 minutes later or an hour later that everything's going to be fine. So we'd rather use the parameters that we know make us feel like the baby's fine, like, is the baby moving? Do your kick counts, all the other things that are kind of tried and true for us to say, if this is happening, then we're relatively sure that right now your baby's okay. And we can't say that from a 1 second listen to a baby's heart rate. Yes, it's exactly what you said. Congratulations, you found something that sounded like 150 for a second or two, and you don't know what's happening a second or two later. So it's not a great way to, I wouldn't want people to be reassured by it, and I wouldn't want them to be panicking because they're hearing the wrong thing. So we in OB are really not big fans of having that at home.
My question is for the people that do the hand Doppler and maybe they're birthing at home or out of a hospital, when they're hearing a baby, okay, my baby's 150 all the time, but there's D cells when you're having contractions or even Braxton Hicks. They are assured by the midwife, like, hey, it's going to go back up or whatever. But since you're not a medical person, how would you know if it's going up the right amount of time? How would you know anything? Because it's just a little hand Doppler and you can't see and you don't know anything and you're not medically trained. So it's kind of one of those, like when it comes to D cells especially with a hand Doppler and at the end of when you're going through labor and contractions, like it doesn't work like that, right?
Yeah, because especially since the most important thing about a deceleration is where does it happen in relation to when the contraction happens. If you're about to push a baby out and you listen with a Doppler and you have a contraction, you hear a big decel, if that deceleration comes at the very beginning of your contraction, that's head compression. Any baby would have a deceleration when you're squeezing its head with your contraction and you're pushing. And that's not non-reassuring. So if we see it on sometimes, funny story that I'll have somebody laboring with a good epidural, and you know how I know they're ready to push the baby out? I look on their tracing and I see these early decelerations and I know, oh, it looks like the baby's head's all the way down. I better go check. And sure enough, there's hair right there and I can push the baby out and they don't feel a thing. And that's a great way without having to continually examine someone, which I don't believe in a lot of exams during labor unless necessary. But that's a good way to say, okay, you rest. I'll watch your tracing. When I see that it's telling me that you're probably about to push, I'll come back in, So it's funny. And that's why you can't with a hand Doppler. Who knows? Are you listening to the middle of a contraction, the end of a contraction, which those decelerations have a totally different meaning, totally not reassuring, and better get the baby out, So another reason not to really rely on that.
Midwife is checking a baby in an out of hospital environment with a Doppler during labor. What are they hearing and how much information can they get out of it? Unless I think the criteria is listen completely through a contraction. And I think a minute after too is what you're supposed to do. Yeah, but I mean,
you're getting anything out of it.
But yeah, no, there's been so many stories where people are like, oh yeah, we heard the baby's doing fine. And I'm like, and then
I hear things a lot like, my baby had a perfect heartbeat. Like, I don't even know what that means.
Yeah, that doesn't mean anything, especially since my son had deep decel early in labor, but then that didn't really recur, but he ended up tachycardia and flat, which is a very concerning finding. And I had no idea that it was until they told me about 5 minutes before a C-section. D cells are obvious. You look at them on the strip and you're like, whoa, baby, this is not good. We need.
Yeah, especially since one of the most important things is looking at this tracing overall, like you're looking over a 20-minute or a 15-minute period of time. So listening with a Doppler, yes, there are studies that say intermittent listening throughout labor is sometimes okay, but that means when all other criteria are okay, right? There's no meconium, there's no question about, your placenta, and you don't know all of that at home, right? So it's harder to say, if I have a Doppler, I can tell you the pattern of this fetal heart rate. You can't tell anything about the pattern. You don't know.